Thank you, Allison. And in Allison's remarks, she touched on the complexity of the issue at hand, and that's exactly what our panel is going to get into today. So I'd like you to help me in welcoming Mark Miller, the Executive Director of the Medicare Payment Advisory Commission, and Brian Rye, Senior Healthcare Policy Analyst, Government Team from Bloomberg Intelligence. So they are going to be discussing the issues today. And with that, I am going to hand it over to Mark Miller, who will make some remarks before starting the discussion.
Probably want to wait to see what I'm going to say before you applaud. Okay, so I think what I'm doing here today is, I've been told to say and remember to thank you for asking the Medicare Payment Advisory Commission to come to your event today. My name is Mark Miller. I'm the Executive Director. Okay, so what I think I'm doing here today is to talk to you a little bit about how to set up some of the issues that you're going to be talking about through the rest of your event. I think the format for my talk is a little bit different. I'm going to talk to you for about 15 plus minutes, lay some things out, then there's going to be some Q&A, and then I think you go to something of a different format. First thing I want to tell you before I get going is who we are and where we are in the environment. So we're a legislative branch agency. We're nonpartisan. We've existed in our current form since 1997. There have been forms of the commission before that date. We're required by law to produce analysis and recommendations to the Congress. And as I tried to emphasize, we serve both sides of the aisle, both houses of Congress, that kind of thing. Also, the Congress is not required to take our recommendations. We make recommendations. The Congress decides whether they want to take them up. The next point that I want you to get is get a sense of the debt and Medicare's relationship to it. Obviously, people care a lot about making sure, the other thing I should have said, this is about paying for Medicare, I think is the title of the session. So a lot of my comments are going to be on payment. Quality and coordination obviously have an important role, but given time and all the rest of that, I won't be getting into a ton of it. And here's the first thing about payment. So, there are slides. Okay. So the first thing to keep in mind is that while it's about getting services to beneficiaries and it's about paying providers and plans fairly and equitably, there is also, you have to keep in mind that this is a taxpayer-funded program, and this is a program that is paid by beneficiaries' premiums, so you have to be very conscious of each dollar that is spent. And now you don't have to read very far into your news sources to understand that the country has a very large debt. So right now, the current estimates are that debt is equal to 74% of the size of the economy. There was a huge spike in that debt in 2010 when the recession occurred. And that is historically unprecedented in the amount of debt that's being carried. The other thing that I want you to get at this point is that Medicare's spending historically can be kind of thought of this way. Per person spending, meaning the numbers of services and how much you pay for those each services, has historically grown very rapidly, and the numbers of beneficiaries has grown relatively slowly. However, in 2010, that shifted dramatically. The utilization of the program fell. And actually, utilization in both the public and private sector fell. And in the commercial private sector, utilization fell, but prices continued to go up, which I'll talk about in just a second. In Medicare, utilization fell, and because a lot of those prices are governed by law, they didn't go up. And so the current, or the per capita spending fell to a very low rate of 1% in 2010, 2014, in there, which would be great news from a deficit point of view, except that at that moment, the baby boom hit the Medicare program. And so what you got was a lowering of the per capita spending, but an increase in the number of people entering into the program. And so at this point, projections are still that Medicare grows faster than the economy and continues to be part of the issue whenever the debt and the deficit will have to be discussed. So that was the first point I wanted you to get out of this. The next thing I wanted to point out to you as we, just before we get into Medicare proper, is that there has been a tremendous amount of consolidation in the healthcare market. Now, I'm going to talk mostly for this moment about hospital consolidation. There's also consolidation in the insurer markets. Given time and the fact that the story there is a little bit more complex, I'm not going to say that much about that. But just to give you a sense, in the hospital market, there's been a tremendous amount of mergers and acquisitions for the last 20 or 30 years, and most of that, until recently, was horizontal consolidation, so buying other hospitals, developing hospital systems. We have many markets in this country in which they're basically one hospital systems. The effect of that, and the research on this has been relatively clear, that there's not a lot of effect on quality, but prices in the commercial markets have gone north at a very rapid rate. In commercial insurance, on average, commercial insurers pay hospitals 50% above their costs. So prices in the private sector have continued to climb, and a lot of the economist types attribute that to market consolidation and market power on the part of the hospitals. The next thing is, I'm completely out of breath because I don't have a lot of time. Okay. Is this like making any sense, or am I just like, I'm in the wrong room? That type of thing. All right, it's fine. I'm going to just do it anyway. Okay, the second type of consolidation is vertical consolidation. And once again, you don't have to read far into your news sources to know that hospitals have been purchasing physician practices. There is an immediate revenue benefit of doing that. I don't have time to explain it, but take it from me in the following way. Generally, in commercial and Medicare, if you pay for a service in the physician's office at this rate, and then you say that that physician office, even if you don't move it, is now part of the hospital, the payment rate goes way up, the facility fee, and I'm getting some nods. Excellent, so I don't have to explain that. So there's a revenue benefit, and of course, this is greater consolidation and potentially greater market power on the part of the hospitals. Now I'm going to stop there on consolidation. Once again, there is a phenomenon on the plan and the insurer side. The story is a little bit more complex, and so I don't really have time to kind of grind through that. The next thing I want to get into your heads, and this is all by way of trying to help you think about the rest of your day, because after this I'll be gone and you'll be on your own. Okay, here is a way to think about the Medicare program. There's probably a ton of ways to think about the program, but for the purposes of discussion, here is a schematic, or whatever you call this type of thing, to think about the Medicare program. So 60 million some odd Medicare beneficiaries. 30 million of them are in traditional fee-for-service. And traditional fee-for-service is probably what most people are familiar with. This is your default enrollment. This is you go and see any willing provider. The provider gets paid largely off of a fee schedule, or whatever the case may be set by law. The kinds of issues that I think are going to attach here as you're going forward, there will continue to be a lot of focus on program integrity in this environment, because the environment tends to be at the margins, somewhat unruly, and so I think there'll continue to be program integrity focus. There will be focus on the payment rates. How much should hospital payment rates go up? How much physician payment rates should go up? But also, because of that consolidation thing I was telling you about, and other reasons, I think you're going to start to see policies that talk about how you pay across site of care. If it's a similar patient in a similar service in the post-acute care setting, skilled nursing facility versus an inpatient rehab facility, or it is an ambulatory service, physician's office, a clinic, and an outpatient hospital, what rates should you be paying? These rates have come out of a lot of history in the Medicare program, and so I think there'll be a lot of focus on that. And then there'll be the kinds of things that you do read about. They'll be looking at bundling services together to try and bring some pressure on utilization. And I also think there'll be discussions about beneficiary cost sharing, whether there's a first dollar coverage in insurance or incenting different services based on co-payments and that type of thing. The middle vector is accountable care organizations. There's now 9 million people in accountable care organizations. Now, those are really fee-for-service operations, but they're fee-for-service operations with a top line. If you come in below that line, you share savings, and if you exceed that line, most of the time, nothing happens. Some of them take risk and actually have to pay that back. And I think the kinds of questions you're going to get there are, where are ACOs going? Are they going to accept true risk? because at this point, the program doesn't deliver a net saving to the budget and to the taxpayer, and that's in part because those plans that do well get rewards. Those plans who do poorly don't get any kind of penalty or have to pay anything back. Other kinds of issues, ACOs were constructed on a historical baseline concept. ACOs very rapidly figured out they couldn't beat their history forever. And so now there are discussions about different ways of setting the baseline. That will be an issue. And also I hear, and these are just a smattering of issues, I hear a lot from ACOs, how do we get the beneficiary to keep coming to us? Because remember, this is a fee-for-service environment, and the beneficiary can wander off and go somewhere else if they choose to do. And so I think there'll be discussions about that. And one final comment, I think the dynamic will be, if the ACO accepts risk, what kind of regulatory relief do they get from kind of the standard fee-for-service rules? And I think that will be kind of the vector of the conversation on risk. The last thing on the far right is, of course, managed care. Managed care, about 17 million people. It's about a third of the program. And I think there was this great concern after the health reform law was passed that, the managed care program would kind of implode. That did not happen. Two very positive things have continued to happen. Enrollment has been going up 9% annually since 2010, and the bids in managed care plans on average have become more competitive relative to fee-for-service, although on net, the program still is not delivering net savings across the entire program. Again, a smattering of issues. If I was talking to, people like you, apparently. It will be things like, is risk assessment accurate? What to do about the coding behaviors that are being observed in class or among different plans? And then finally, in quality, how do you have low burden, meaningful quality measures that also are adjusted for the fact that I might have a much more complex population than you have? Okay, we're into the home stretch here. Okay. So then, drugs, and home stretch means 2 more slides, okay? So if you're having a bad time, we're almost done. Okay, so Medicare drug spending, and drug spending in general. There has been a lot of attention to this issue, and price increases and a lot of individual drug and newspaper stories. So in the Medicare program, drug spending is 20% of the spend when you consider the Part D outpatient benefit, the Part B in the physician's office drug infusion, and then drugs that ripple through the fact that you're in the hospital and the hospital's giving you drugs, the skilled nursing facility, that kind of thing. For Part D, we're talking about a $100 billion program. Some of the issues that I think are going to rise there is when Part D was passed, in some ways, the market was, it was a great time for it to pass because the market was moving to a lot of generic drugs at that particular point in time. Pipeline is shifting now back to sole source, biologics, and biosimilars. And so I think that there's going to be some upward pressure on the cost in this particular program. Once again, you don't need to read very far. There seems to be a lot of price increases in general, even among generic and drugs that have been around for a long time, which I also think brings cost pressures here. Remember this session about paying for Medicare, that type of thing. And then there is also more beneficiaries hitting the catastrophic cap. The catastrophic cap is where the risk shifts from the plan to 80% federal, and that cost inside the Part D program has been escalating very rapidly for the last several years. We have been pointing this out, but I don't get the sense that a lot of people are tracking on it. So the federal government's portion of this program is the most rapidly growing portion of this program. And eventually that's going to punch through, and I think that that's going to create questions about where the risk should be held. We recently made recommendations in June about changing the risk between the plans and the federal government. If anybody wants to talk about that, we can take that on question. Part B drugs, $22 billion. These are different. This isn't your outpatient drugs. These are, I'm in the physician's office, I'm getting infused for chemo, I'm getting infused for some other, rheumatoid arthritis, those types of drugs. Here, the growth rates are about 8% annually. About half of that is price. There is a lot of attention and concern that the way it is structured is incenting people to more expensive drugs, although I think the evidence on that is quite mixed and unclear. Here, people are going to be looking at the basically fee structure and looking at ways of restraining those prices, and I think there will be conversations about could you take that and put it more on a competitive platform like the Part D program. So I think there'll be some conversations about that. And part of the reason I think that is that the Commission is having both of those conversations right at the moment. Okay, we're in the home stretch here. Last slide. Right. Okay. So premium support has come up and is a source of, or point of a lot of discussion. Commission's been writing about premium support, for the last 4 or 5 years. We presented last month. We're going to have a big report on it in June. This has been planned right along. And I think our objective is to take every issue and make it boring and technical, as you've followed this talk so far, right? And so the thing is like if this conversation is going to occur, how do you design it to be most effective? And there's at least a few things people should keep track of, and I'm just going to name a few of them. There's more than these. One, risk adjustment. Is it powerful enough to adjust in a premium support system, given where beneficiaries may end up, fee-for-service, this plan, that plan? Number two, there is geographic variation across this country in the utilization of services. I know this is a complete shock to you guys, but Miami, very high utilization, Seattle, low utilization. How you set the federal subsidy, whether you do it nationally or whether you do it by market, will have very large equity issues and how the premium impacts fall on a beneficiary in any given market. And the other thing, which I think a lot of people miss, is, yes, beneficiaries in certain markets, if they want to stay in fee-for-service, would have to pay a higher premium. But beneficiaries in other markets who want to stay in managed care will also have to pay a premium depending on how those benchmarks are set. Let's see, what else? Oh, and then there is the issue of low income. So low-income folks can't afford their premiums. There will have to be some scheme for subsidizing. And then there will be the question, as you found, like in Part D, and as you found in Part D, if somebody doesn't make a choice, where are they defaulted to? Fee-for-service, managed care plan, whatever the case may be. And I'll tell you what, with that, I'll stop. So we're going over here.
That seat over there.
Far.
Yeah. Thank you. We'll give you a chance to get a drink of water. My name is Brian Rye. I'm a government policy analyst with Bloomberg Intelligence here in Washington, D.C., and we want to open this up to questions now. I'll start with one while you all formulate yours. The only request is we'll try and keep this policy instead of politics. In the last month alone, the Chicago Cubs won the World Series, and Donald Trump was elected president of the United States. So the idea that anyone can predict what's going to happen right now is not one that I really subscribe to. You touched on the Part D program. There's been some talk that maybe Congress should revisit the non-interference clause that was embedded in the 2003 Medicare Modernization Act. It's been a while since the CBO looked at that, but when they last did, they sort of concluded that by itself, that really wouldn't impact federal spending, essentially saying that insurers and PBMs are already getting the best deals they can. You touched on some MedPAC recommendations, so maybe now's a good time to talk about what some of those recommendations are.
Yeah, I will do that. You're exactly right that when CBO looked at this issue, what they said was, given what the insurers would extract, or the insurance plans would extract, they weren't willing to attribute a lot more effect to a government negotiation. It's been a lot of years since that happened. I don't know what they would necessarily say or do today. And as I mentioned, to some extent, the market has shifted. And so, I want to be clear, I truly wouldn't know, and the CBO folks would have to work through that. The recommendations that we made, there were 3 that I'll point to, just at a high level, so I won't get real technical. The one is, to take the catastrophic cap. There was great concern when Part D was being created back in the day that nobody would show up, no plans would show up, which in retrospect seems a bit naive. And there were lots of things put in the program to make it, to manage the risk. And so the catastrophic cap, which keep in mind for standard managed care plans for hospital and physician services, there isn't a catastrophic cap that the federal government comes in behind them. But a catastrophic cap was created, and it was 80% liability for the federal government at that point. There's also the corridors. We're saying that the market is mature enough, and given the way insurers manage their AB benefit, that much risk doesn't need to be held by the federal government. We switched it to 80-20 plans, and plans can enter the reinsurance market and that type of thing. We switched it to 80-20 plan government, and we also took the beneficiary's liability out so that when they hit the catastrophic, they stop paying, because some of these drugs, even a 5% liability after you hit the catastrophic cap, the commissioners that I work for were concerned about that. The second thing we did is we said, well, if we're asking the plans to take more liability, shouldn't we also give them more flexibility and tools? And so we made a set of recommendations on these tools should be relaxed to give the plans more ability to do it. One of them was to say go into the protected classes of drugs and take 2 of the protected classes off of that status. As you can tell so far, all of these recommendations were highly popular. The third thing that we said is that we think price signals matter to beneficiaries, and they will follow those price signals. We also think it's true for poor people. Now, you don't want to expose poor people to high cost sharing, but could you have a greater range of price signals? So, for example, if you say to a beneficiary, because their price or their cost sharing is dictated by law, say you can have a 0 cost sharing if you go for the generic versus, I'm making this up, $7 for the name brand. Is that enough of a single signal that you can actually steer a poor person? So those were the recommendations.
Sounds good. Open it up to the audience. Yes, right. I think we have microphones coming around as well.
Lynn Snyder from Epstein, Becker & Green. Can you talk about how the numbers might look different now that the #1 growing sponsor of Medicare Advantage are provider-sponsored health plans under MA? A lot of our integrated delivery system clients are already converted over to pay for value for their commercial population, and then they are starting their own Medicare Advantage plan. So from a Medicare Advantage standpoint and from a Medicare fee-for-service standpoint, can you just tell us what you think? Because I know a lot of your Part A and Part B fee-for-service kind of assumes that it's in isolation, but we're seeing more of these integrated delivery systems already converting over. Do you think that would deflate the fee-for-service side of the equation?
Oh, so you're asking a spillover effect. Is that what you're asking? Yeah. Because I could have seen a couple of different questions in there. So I think there is some back and forth. Right, let me back up and say 2 things. Actually, now I'm going to reverse it. This is all happening in my head, in case you're wondering. I think there is some spillover effect. I think if people think that it is going to, be very large and, alter the dynamics, across the board, I'm more skeptical of that. I've seen the research. I do think there's an effect. How pronounced and how consistent and how deep it would go. I still remain like, let's see how this goes. But I don't think it's 0 by a long shot. And so I do think that there's probably something there. So I'm trying to agree with you, but to have some degree of caution in that. I think the more difficult question in all of this is whether you're talking about an ACO provider, underneath a fee-for-service type of regime with a benchmark, or managed care, there's still a number of questions whether on net this turns into savings to the taxpayer. And I want to be really clear here. I think some of the results on ACOs and then managed care, because those are the sort of organizations that I think you're talking about rolling into managed care, not all parts of the country and not all managed care plans bid below fee-for-service. Many of them bid above fee-for-service. And I just want to be clear to anybody in the room who doesn't understand what that means. It means it costs them more to deliver the standard Part A and Part B benefit than it does in the fee-for-service. Then there are other markets in which managed care is definitely underbidding fee-for-service. So exactly how these models work in any different setting, I think, is something of a question. Whether, I will not say, oh yeah, automatically it translates into a slowdown in spending, everything's good, lots of spillover. So I would say I think it's going to be variable in the effect that you're going to see, and I think it's going to be in how much spillover, and I think it's going to be variable in the effect that you're going to see across the country.
So just to follow up, the Medicare Advantage is a defined contribution way of dealing with the federal government's responsibilities for this population, and the Medicare fee-for-service is like a defined benefit.
I think that, I'm not sure I would characterize.
Is there an advantage to even having it budgetarily under some type of premium as opposed to a la carte where some of the Part A and B rules create these inconsistencies in the marketplace that are to some extent skewing the way in which people price their products?
I understand. Okay. So, two things. I'm not sure I would characterize MA as a strictly, what did you call it?
Defined contribution.
Defined contribution, because they have to deliver the same benefit that's in AB. Where they get their flexibility, which I think it makes a lot of sense, is how much the beneficiary pays. And they can do a lot of things, but mostly what they do is they forgive cost sharing and reduce cost sharing for the beneficiaries, which is one of the reasons I think these plans are attractive. So your hard line distinction between one is a defined benefit and one is a defined contribution, I'm not quite sure I would characterize it that way. But I get your point on doesn't it shift the dynamic? I think the Commission's view of this is decidedly, to the extent that a provider group or a managed care plan assumes the risk, there is downward pressure on utilization. But the thing I think you and anybody else in the room need to track to is there's two questions underneath that all the time. And I tried to touch on this, but it was roaring fast, and even I couldn't tell what I was saying. So, does the model work? That's one question. And I think there's a lot of people who are sort of, yeah, these models work. I think the evidence is much more mixed than that. And then the second thing is, if it works, what do you do with the payment? Because in the ACO world, for example, one-sided ACOs actually show a very small reduction in utilization, which you would say, oh, so they saved money. But if it's all given back and rewards on top of that, then the taxpayer and the beneficiary don't see it. So my answer to your question would be, great, how are you paying behind that model to know how to answer your question? Is that, we actually were clear? Okay.
I think you go here next.
I had a moment there.
Thank you. Leslie Freed, National Council on Aging.
I know who you are.
Well, others might not.
Oh, you're right. I'm sorry about that.
So it's not all about you, although right now it is. My question actually goes to the beneficiary and some concerns about premium support and the impact on beneficiaries. And we hear some members of Congress of using Part D as a model. But what you all have studied and others is that people don't shop. I mean, they make their first decision, and then a very low percentage, maybe 13% of people change their Part D plan or even shop because it's too complicated, it's too hard. We know that there are low-income beneficiaries at LIS, over about 700,000 who are paying premiums, maybe not necessarily because they just didn't change. So can you talk about the Part D experience when we're thinking about premium support and the impact on Medicare beneficiaries?
So I think if I followed the construction of your question, you're right. people tend to be sticky, and they aren't, these aren't even Medicare people or poor folks or anyone else. I think most people are sticky in their insurance. In your own room, you don't have to say it out loud, but just think out loud when you got the choice. How often, have you switched if you got the choice? So I think, and again, since I was focused on payment, there are other parts of this conversation that have to occur, which is if you go to a system like this, what information support are you going to provide to beneficiaries in order to support these kinds of decisions? And I touched on it, and I know it's very much a flashpoint. What happens in a default type of situation, which is a huge question. So I think if we're going to have conversations about these apparatus, we might be saying, well, in some ways, the prices and the payments begin to take care of themselves because of the market, but there are whole new sets of responsibilities that Medicare would have to engage in order to support the beneficiary's choice process. So that's one thought. The second thought I would say is, I think there is movement, and I think people move, but they move slow. So, for example, what happens in Medicare is you come into fee-for-service, and then what you're finding is 1-2 years later, you're getting a fairly rapid movement out of fee-for-service into managed care plans. Then how much movement there is at that point, I'm less clear on, and I'm hazy on at the moment. But I do think, depending on how clear the price signals are and if they have supporting information, I think beneficiaries can make this choice, can make these choices and might be less sticky over time. They haven't had a lot of reason to move in Part D because the premium portion of that program has not grown rapidly. It's the back-end federal portion that has been going up at something like 15% and 17% annually. If that was more spread across the plans and the beneficiaries in the federal government, you might get different kinds of behavior there.
Okay, you
She's
finished.
not happy with the answer.
She's going to grab you on the way out.
I'm sure she will.
You did finish your presentation a few minutes early, so I'm going to try and squeeze in one more question here in the back. Okay, I think that's all.
We don't have any time for any questions.
Now we have time for. So the next panel.